This is Dr. Hessel recording the podcast on preoperative airway evaluation and prediction of difficult airway for August 12, 2013. The suggested reading is in the latest edition of Barish and Miller, and also Anesthesia Board Review by Ranasig. I think the chapter in Flasher's textbook on evidence-based practice of anesthesia by Gottreich and Hagberg is particularly relevant to this presentation. I'd strongly encourage you to read that chapter. There are also additional references at the end of this presentation. Competence in airway management is an essential characteristic of anesthesiologists, which includes knowledge of the anatomy, the ability to assess the airway, skill with the use of various devices, and knowledge about the application of the difficult airway algorithm. The consequences of mismanagement of the airway range from dental damage to anoxic brain damage and death. These were reviewed by these closed claims analyses from the ASA in the past few years. And of course, you're all familiar with the practice guideline for management of the difficult airways, which has been upgraded. Now, the term difficult airway can apply to many different types of difficulties, ranging from difficult mask ventilation, difficult LMA ventilation, difficult laryngoscopy, difficult intubation, failed intubation, and the worst situation, can't intubate and can't oxygenate or ventilate. Other problems are difficult fiber optic intubation, difficult surgical airway, and complications at extubation, and we'll try to discuss all of these in this presentation. There are many factors that impact difficulties. One of the most important, of course, is operator experience. Another are patient factors, and then there's the circumstances under which you are working. This is a summary of the incidence of various problems with intubation or airway management in the operating room. Difficult laryngoscopy is often defined as a view of 3 to 4, and the incidence is said to be between 1.5% and 13%. The incidence of difficult mask ventilation ranges from about 1 to 5%, but this has been reviewed by a number of authors with quite a wide range, from as low as 0.1% to as high as 15%. Difficult mask ventilation has been defined by various ways, ranging from the best, which is when you can ventilate with a mask, to when you need an oral airway, or when you need to use various devices, two-hand providers, and muscle relaxation. The extreme is the inability to mask ventilate, with or without muscle relaxant. Difficult endotracheal intubation, as defined by the ASA, as requiring more than 3 attempts or longer than 10 minutes, occurs in about 1 to 4% of the time. This has been systematized by this nice article by AdNet about almost 20 years ago. They developed this scale based on counting the numbers including the number of attempts, the number of operators, the number of alternate techniques, Cormack grade, whether lifting force was necessary or laryngeal pressure was necessary. And you added all of them up and got a score. When the score was 5 or more, it was considered a moderate to difficult airway. Failed intubation is said to occur in between 0.05 and 0.35%. In the review by Gottage and Hagbard, they found the incidence of failed intubation in the general surgery in the operating room to be about 1 in 2,000 cases, whereas in OB it's much higher, ranging from as low as 1 in 700 to as high as 1 in 280. The worst situation is the inability to intubate and the inability to ventilate, and Benjamin has estimated this to range from as low as 1 in 1,000,000 to as high as 2 in 10,000. This is a summary of Benjamin's chapter in Chestnut for the incidence of various degrees of difficulty with intubation. Now, the first step is to anticipate these problems by assessment of the airway. This includes a history, the review of prior anesthetic records, the physical examination, and then on occasion various special studies, including endoscopy and radiologic studies, and recently some interest in the use of ultrasound. The history may or may not be helpful, and I've encountered examples of both false positives and false negatives, those in which it was said on the anesthetic record to be easy, and yet I know for a fact it was difficult, and vice versa. An anesthetic record that shows it was difficult, and yet subsequent attempts have proven to be easy. But one should always examine the anesthetic record and be respectful of their findings. There are many lists of components of preoperative examination. This is one list, I think, generated by Benjamin, starting with the length of the upper incisors, the relationship of the maxillary and mandibular incisors, which are described as overbite, and the relation of maxillary and mandibular incisors during voluntary protrusion, the so-called upper lip bite test, the inter-incisor distance, the visibility of the uvula, called the Mallampati grade, the shape of the palate, the compliance of the mandibular space and size of the tongue, the thyromental distance, the length of the neck, the thickness of the neck, and importantly, the range of motion of the head and neck. This is a table from the chapter by Gottage and Haberg, referring to these various components and what findings are non-reassuring. This is from Basics of Anesthesia, again reviewing non-assuring findings. And finally, from this review article by Mace in Emergency Medicine Clinics of North America. And finally, the chapter by Benjamin in the 2004 edition of Chestnut. One of the most common findings on physical examination, which are commonly used to assess risk of difficulties is the Mgmt classification described more than 20 years ago. This test requires that the patient be sitting up and that they stick out their tongue, but they should not phonate. There's also a difference of opinion as to whether the patient should extend the neck or keep the head in the neutral position. We'll discuss the validity of this test subsequently. This is another picture of the Mgmt test. There's a lot of variability between class 2 and 3. Class 1, when you have an excellent view of the uvula and the tonsillar pillars, and some have even added a class 0, which is when you can see the tip of the epiglottis. At the high end, the class 4 is when all you can see is the hard palate and none of the soft palate. Another test which was described about 10 years ago is the so-called upper lip bite test, described in this article by Kahn and colleagues. And he described the ability of the patient to cover the upper lip with the lower incisors. Class 1 is when the lower incisors can cover the entire vermilion line of the upper lip. Class 2 is when it can cover only part, and class 3 and when it cannot touch the upper lip. Let us now turn to factors that are associated with or have been used to predict or anticipate a difficult airway. Unfortunately, objective data are hard to come by, partly because of variable definitions of what constitutes a difficult airway. A number of authors have listed various factors that they believe predict airway difficulties, including signs of obstructive sleep apnea, the presence of a beard, a high-grade Mgmt score, age, limited jaw protrusion, short thyromental distance, large body mass index, lack of teeth, which can make it difficult to mass ventilate, but on the other hand, it can facilitate laryngoscopy and intubation, and finally, the presence of a thick neck or reduced ability to move the jaw. On this slide, they have indicated the factors that are associated with difficult mass ventilation versus those that are associated with a difficult endotracheal intubation. In Stolting and Miller, they've listed various congenital abnormalities that are associated with difficult intubations. These are, again, repeated from Barish's textbook, as well as various pathologic states which may interfere with airway management, ranging from epiglottitis to maxillary and mandibular injury, laryngeal fracture, radiation therapy, and inflammatory rheumatoid arthritis, ankylosing spondylitis, sarcoidosis, angioedema, thyromegaly, and obesity. Various infections and obviously interfere with the ability to manage the airway, including supraglottitis, croup, Ludwig's angina, and then various arthritic conditions. The presence of tumors trauma and miscellaneous conditions can all increase the risk of airway difficulties. Now, one of the first steps is predicting difficult mask ventilation. I've already listed some of those factors, and I've already summarized how people have classified the degree of difficulty, ranging from readily availability to ventilate by mask to the total inability to ventilate by mask. And in between are how many maneuvers are necessary to permit mask ventilation. Mace has summarized some of the factors that are associated with difficult mask ventilation using the eponym MONS for problems that make it difficult to seal. Obesity, elderly age, the lack of teeth, and the history of snoring. This was a study looking at the incidence and predictors of difficult and impossible mask ventilation. They indicated in this study of over 17,000 patients that most of the time there was no difficulty, but in 20% they needed to use an oral airway or adjuncts. In another 1% it was more difficult, requiring 2 providers with or without muscle relaxation. And the extreme, which occurred in about 0.2% of patients, they were unable to mask ventilate with or without muscle relaxation. This is a list of independent predictors that were associated with difficult mask ventilation for those that required extra maneuvers, high body mass index, the presence of a beard, high Mallampati grade, older age, and then those that predicted more difficulties you can see on this slide. There was a relationship between difficulty in mask ventilation and difficult with intubation. Of those that had a grade 3 mask ventilation difficulty, 23% had a difficult intubation, and those who were unable to be mask ventilated, or it was severely limited, it turned out that in 70% intubation was easy. In about a quarter it was difficult, and in 3% they were unable to intubate by direct laryngoscopy. I've already shown this slide of things that predicted difficult mask ventilation by Griesdale and his colleagues. This was a review of 50,000 anesthetics predicting impossible mask ventilation. And they found that this occurred in 0.15% of cases. And on the bottom table shows the outcome of these patients. There were 77 of them. As you see, 58 were able to be intubated without difficulty, whereas one of the 3 of the patients had to be awakened or required emergent. I should say 4 of them had to either be awakened or required emergent cricothyroidotomy. And this shows the risk factors for impossible mask ventilation. The highest was neck radiation changes. Interestingly, male gender, sleep apnea, high mallampati scare, and the presence of a beard were all predictive, but not very strong. This was a study from about 10 years ago from Scandinavia, listing risk factors for difficult mass ventilation. And I thought it was interesting because it described virtually all of, or a large percent of patients that we encounter here at UK. Absent teeth, presence of beard, obesity, history of snoring, etc. Now, there are also factors that are associated with difficulty with placing and successfully ventilating the patient with a supraglottic airway, which of course is extremely important since this is often the rescue technique that you use. In this review by Mace, she mentioned the use of the term rods for restricted mouth opening, upper airway obstruction, disrupted or distorted airway, and extremely stiff lungs or a stiff cervical spine. Much attention is given to predicting difficult intubation. And starting out is important that it's essential to have optimal conditions before you try intubation and laryngoscopy. And when assessing whether it's difficult or not, the first question is, has the operator achieved optimal conditions? This first begins by having a reasonably experienced practitioner participant. The patient should be totally muscle relaxed. The patient should be positioned in the sniffing position, and you should use an appropriate type and length of blade, and supplement, if necessary, with various manipulations of the larynx, such as the so-called burp maneuver, or pushing forward on the cricoid cartilage. I've already referred to this so-called intubation difficulty scale, which is used in a number of studies in assessing the predictive value of various parameters. This was described, as I've already mentioned, by Oddnet about 15 years ago. These are the details of the scale and the rules for calculating the IDS score. And as I've previously stated, a score of 5 or more is considered risk of moderate or major difficulty with intubation. Again, Mace has listed some of the factors that are associated with difficult laryngoscopy and intubation. Now, part of the problem in assessing these various factors is because there's a various definition of difficult airway. But one of the most common definition is a high-grade Cormack Lehane grade. And I've summarized on this slide what the classic grade was. Grade 1 is where you see the entire larynx and vocal cords. Grade 2 is when you only see the aryepiglottic fold. Grade 3 is when you only see the epiglottis, and grade 4 is when you don't see the epiglottis. This is another picture of the various grades. You notice in this diagram they've included as grade 2 the fact that you see some of the chords as well as the area epiglottis. Now, this was modified by Yentis and Lee to dividing grade 2 into grade 2A and 2B. 2A is when you see some of the vocal cords, and grade 2B is when you see only the arytenoids. Grade 3 again was when you only see the epiglottis, and grade 4 is when you don't see the epiglottis. Now, Cook has further modified the grade 3 classification, in which you can only see the epiglottis, into grade 3A when the epiglottis can be lifted, and grade 3B when the epiglottis is seen but it can't be lifted. Based on this, Cook has stated that when it's grade 1 or grade 2A, which means you see part of the vocal cords, 95% intubations are easy, and about 3% may require adjuncts. When it's a grade 2B, meaning that you only see the area epiglottic folds, or 3A, when you only see the epiglottis but it is mobile, he thought it was likely that this patient could be intubated with the aid of a gum bougie. Whereas when you only saw the epiglottis and it was not mobile, or you couldn't even see the epiglottis, he felt that intubation would only about 75% time be possible, and often requires adjuncts and may be impossible. However, a poor Cormack Lehane view does not always imply difficult intubation. This study from about 7 or 8 years ago of 1,000 patients in whom 130 had or 12% had a grade 3 or 4 view. Of these patients, 44% were intubated on the first attempt and 42% on repeat attempts, whereas only 15% required an alternate approach, either using a fast-track LMA or fiber optic bronchoscopy. Even in these patients, they had only 3 patients in whom saturation fell below 85%, and there was no morbidity or mortality. These are the various anatomic conditions that are associated with difficult rigid laryngoscopy. Benyamoff has identified 3 of the important factors. One is the anterior larynx, the second, the prominent upper central incisors, and the third being difficult size or motion of the mandible. In their review article published in the book on evidence-based anesthesia, in their table 1, Gottage and Hagberg have summarized the single predictors that have been used to predict difficult intubation. And this is from that chapter in Flasher's book on evidence-based anesthesia. They concluded that no test has an adequate sensitivity without substantial false positives. they all have a low sensitivity and positive predictive value with a specificity of between 30 and 70%. As far as the Malin-Patty test, he concluded that the sensitivity was about 70%, the specificity about 60%, and the positive predictive value only about 20%. This was a systematic review of the accuracy of the Malin-Patty test published about 7 years ago. And they said one problem is the poor to moderate inter-observer variability and the only poor to good accuracy. They concluded that used alone, Malin-Patty tests are insufficient to confidently predict the presence or absence of difficult airway and should form only a limited part of the overall assessment of the airway. Another test that has been suggested is the upper lip bite test, which I have already described to you. And when used in 300 patients, compared with they compared the reliability of a upper lip bite test class 3, which meant the patient could not cover the lip at all, versus Malin-Patty class 3 or 4. They found the upper lip bite test had better accuracy, better specificity, better positive predictive value, and a similar negative predictive value. This was another more recent study of the reliability of upper lip bite test, and they concluded that both tests were poor predictors as single screening tests. You see in this study of 1,000 patients, their upper lip bite test was 1 in 60%, 2 in 30%, and 8 in 3%. They said it had a sensitivity of 28%, a specificity of 93%, and a positive predictive value of only 34%, and a negative predictive value of 91%. So they did not find the test to be as optimistic as Kahn did. Another parameter is the ability to extend the atlanto-occipital, the ability to extend the head on the neck, the so-called atlanto-occipital extension, and ideally you'd like it to be more than 35 degrees. This was a excellent meta-analysis of various bedside screening tests of the ability to predict difficult intubation in apparently normal patients using various bedside screening tests. They indicated that each test yielded a poor to moderate sensitivity and a moderate to fair sensitivity, but that the combination of Malin-Patty classification and thyromental distance might be the best combination. But unfortunately, they concluded that the clinical value of bedside screening for predicting difficult intubation remains limited. These are the receiver-operator curves for the Malin-Patty test with a ratio of 0.8, the thyromental distance with a area of 0.6, sternomental distance 0.8, mouth opening 0.7, the so-called Wilson rank score 0.75, and combinations of about 0.85. None all better than chance of 0.5, but none really high, up around 0.9. Now, there's been a question about whether obesity is a predictor of difficult airways. In the past, it was thought to be predictive, but this article here concluded that obesity, when adjusted for associate variables such as age and gender and thyromental dysfunction and Mallampati score and history of obstructive sleep apnea, that obesity alone was not a predictor. On the other hand, this paper said that difficult intubation was more common in obese versus lean patients. This was a review of the experience with tracheal intubations in morbidly obese patients. They said that in 12% of these patients, intubation was problematic, but that they were always able to intubate the patients. They found that the Mallampati score and neck circumference of over 40 centimeters was predictive, but that BMI alone and obstructive sleep apnea alone were not predictive of difficult intubations. This is a summary from Benyamov's chapter on the relative risk of a difficult intubation, comparing the risk in patients with a Mallampati class 1. And you see class 2 had 3 times increased risk, class 4, class 3 7 times, and class 4 11 times. Short neck 5 times, receding mandible 10 times, and protruding maxilla 8 times. This was a summary of these various individual factors for predicting difficult airways, which is basically a summary of what we've already said, that none of these are particularly accurate. This shows the sensitivity, specificity, and positive predictive value of all of these various individual tests. The one most predictive was a history of difficult intubation, whereas most of the others had a positive predictive value of only between 10 and 40%. Although, as you see, the next most powerful was a short thyromental distance. Now, instead of using individual predictors, a number of studies have used combined predictors. And in the review chapter by Gottage and Hegberg on evidence-based anesthesia, in their table, they summarized 10 studies, and in the text mentioned a total of 18 studies. They indicated that few of these have been assessed prospectively, and even combined predictors, none of them have provided satisfactory results in terms of sensitivity and specificity. And finally, there are particular problems presented by the pregnant patient, the pediatric patient, and those undergoing airway surgery. Some of the various combined parameters that have been used is the combination of the Mallampati score and the thyromental distance, the so-called airway difficulty score of Jansen's, the Wilson rank sum, the Wong's regression equation, the composite airway risk score of El Gunzori, and Arne's multifactorial risk index. This I've already reviewed the article by Shiga on predicting difficult airways, and again they emphasize that even combination scores were not satisfactory. This is from the Gottage-Hagberg article chapter, and summarizes these various multivariate predictors of difficult airway. What the authors concluded is that you should look for individual predictors, but realize that none are perfect. And it concluded that the practitioner should always be prepared for having a difficult airway cart available and practicing difficult airway drills. This was a recent article published last year of predictors of difficult intubation as defined by the Intubation Difficulty Scale, and looked at the predictive value of 7 airway assessment factors. These were the 7 airway predictive factors that they used: Mallampati, thyromental, head and neck circumference, BMI, the presence of prominent upper incisors, the interincisor gap, and the upper lip bite test. And they gave points from 0 to 2 on each of these parameters, and then added all the points up to get a airway risk score. So for Mallampati, if you were a 1, you got 0 points, a 2 got 1, and 3 or 4 a 2. For thyromental, more than 6.5 centimeters, a 0, less than 6, 2. For BMI, less than 25, you got 0, and more than 25, you got a 1. Remember, this is from Korea, so probably they don't have the same problem with obesity that we have. They were very subjective in regards to prominent upper incisors. They did objectively assess the interincisor distance. If it was greater than 5, they got 0 points. If it was less than 4, they got 2 points. And upper lip bite test, you can see here, 0 points, 1 point, and 2 points. They then rated the difficulty using the intubation difficulty scale, and they considered those that the intubation had a score of more than 5 as representing difficult. And these were the results of the individual airway factors and the incidence in patients who had difficult airways. And they then used a logarithmic analysis to give the odds ratio of these different airway factors. Finally, there's the problem of predicting a difficult surgical airway. This is very important since this is often your rescue technique. And they emphasized if there was a disrupted airway or hematoma or infection, obesity, which would make access to the neck difficult, radiation of the neck, and tumors. So in these patients, one must be particularly cautious since a surgical airway may not be available as an escape method. Finally, one should take into account risks of having problems after extubation. And these are listed and discussed in Barish, the latest edition, on table 27-14. So they include pre-existing vocal cord abnormalities, various types of surgery, and then local or generalized edema. And I add here a history of large intraoperative fluid administration, tracheomalacia, various conditions like Parkinson's and rheumatoid, angioedema and anaphylaxis, history of obstructive sleep apnea or hypoventilation system, and I add depressed central nervous system function and prior use of neuromuscular blocking agents. Finally, I'd like to emphasize the fact that there is increased risk of difficulties with intubation outside of the operating room. This includes not only the ICU and on hospital wards, but also in the ER and during pre-hospital care. This was brought out by this recent review from the British Health Service, and they found that compared with the operating room, when intubations were done outside of the operating room, either in the ICU or in the ER, or on the floors, that these patients had more risk of death or persistent neurologic injury, and that there were repeated gaps in care when intubation was done out of the OR, including failure to identify at-risk patients, poor planning, inadequate staffing, delayed recognition, and failure to use and interpret capnography. This was associated with an editorial which emphasized that there's a low risk of failed airways, but when they occur, they're associated with a bad outcome, and that there is much room for improvement. They pointed out also that when surgical airway was used, which was used in 43% of the failed intubations, when they were done by surgeons, about 20% died, but when they were done by anesthesiologists, only about a third were successful. Finally, when talking about difficult intubation, we need to realize that our main priority should be to avoid hypoxia, not to intubate, and that this is aggravated by difficult face ventilation rather than difficult intubation, and that both of these problems can often be alleviated with a supraglottic airway, and therefore we should consider earlier use of supraglottic airways when encountering these difficulties. In summary, the ability to manage the airway is a key characteristic of an anesthesiologist. Difficulties with establishing an airway is a major cause of adverse outcome. Although these difficulties can be anticipated through history and physical examination, unfortunately no parameters or combined parameters have a perfect predictive ability, and therefore one must always be prepared to manage any of these difficulties, ranging from the inability to ventilate by a mask to the worst of cannot ventilate and cannot intubate. I now have listed a number of questions for you to answer, and we'll briefly go over these questions. The first is, which of the following is not part of a Mallampati classification? The next 6 questions relate to assigning a Cormack Lehane grade based on your view. if you are unable to see the epiglottis, if you are able to see the epiglottis but it can't be lifted, if you are able to see it but it can't be lifted, if you see only part of the vocal cords, if you see the aryepiglottic fold but none of the vocal cords, and finally if you see all of the vocal cords. The next series of questions asks you to estimate the risks of various problems. Question 8 is the risk of a difficult mask ventilation, giving 5 choices. The next is the risk of impossible mask ventilation, giving 5 choices. Next, the risk of a difficult laryngoscopy with 5 choices. The risk of a difficult intubation, given 5 choices. The risk of a failed intubation, given 5 choices. And the risk of the inability to intubate and at the same time the inability to ventilate. That completes the presentation, but I've appended a number of additional resources. These are some articles in the 2011 issue of the British Journal talking about the incidence of major complications in the operating room and outside of the operating room. And these are recent reviews on airway management. And some of the resources I used in preparing this presentation. And that completes this presentation.